Yes, hello, welcome everybody to today's virtual ethical innovation lecture. Slightly different time set because today we have our term's international speaker. I'm really happy to welcome Kirsten Ostherr. I'm going to introduce you in a minute. Just going to say a few words about the format, which is a format which is designed to be a bite-sized introduction into everything that is concerning humanities, ethics, and societal aspects of technology. For those who are interested and that may not come from that area originally, and it's supported by the Academy of Humanities and Sciences in Hamburg. I'm very grateful for that. We are the Ethical Innovation Hub, which is a group that is supported by two of our university's institutes. So the Institute for Electrical Engineering and the Institute for History of Medicine and Science Studies. We work towards an inter and transdisciplinary perspective on taking ethics as a driver of innovation and making good use of ethical analysis to improve upon technological developments. And we have very interesting presentations already this term. We listened to Michelle Fink and Arshad Yeager talking about purpose limitation and data minimization. We heard Martina Filippi about the ethical aspects of UAV-based rescue robotics. And after today's veil, we'll have yet another veil by Rafaela Hilland, who is going to talk about designing for sustainability. But today's veil is going to be about AI and the medical humanities. And again, I'm very happy to introduce Kirsten Ostherr here today. She's the Gladys Louise Fox Professor of English at Rice University in Houston, Texas. She's the chair of the English department there. She is director of medical humanities and director of the Medical Futures Lab. And she's also an adjunct professor at the UT School of Public Health. I think originally you're a media scholar, but you're also a researcher in health and in technology, so probably also in the intersection. Your research is on trust and privacy in digital health ecosystems, medical humanities and AI, so that's what you're going to talk about today. And you're also on COVID recently, or maybe not so recently anymore, because it's been a while that this has been with us. And you're also currently leading a multidisciplinary project called Translational Humanities for Public Health. So probably, unfortunately, we cannot hear about everything that you do today, but before you continue, just a few more organizational words. We are going to hear your presentation in full. Please, if you have any questions, note them down in the chat. I'll make a list and try to get everything covered. But also afterwards, we'll turn off the recording and have a Q&A section where we'll give you also the opportunity to use your video and microphone such way that we can have an open discussion. Okay, and now without further ado, I'm very much looking forward to your presentation, Kirsten, and the floor is yours.
Okay, thank you very much. I will start by sharing my slides. And let's see here. And it looks to me like you are seeing the appropriate slide. Let me know if that's not true.
It's true.
Okay, wonderful, great. So thank you all for being here today. I'm excited to talk to you about artificial intelligence and medical humanities. And I thought that I would focus in particular on the question of narrative challenges or narrative medicine and AI, which is kind of a subset of a larger set of issues that I've been working on recently. I'm actually just back from a week-long workshop at the National Humanities Center in the US, where I'm participating in a workshop which will lead to curriculum at universities across the United States on responsible AI. And the topic of the class that I'm working on is responsible AI for health or health and medicine. And this particular area, I think, is a really interesting one for humanities and engineering or technology development people to think about, because it's a very challenging area in healthcare, and it's one where there's potentially great opportunity for collaboration and for development of new methods, but it's a very challenging area too. So this is mainly what I'm going to focus on. And so there's basically three parts that I want to touch on. One is just to kind of set up why narrative is a challenge, and I'll talk briefly about Watson Health, which some of you may be familiar with, the IBM effort at doing AI for healthcare. And then I'll talk a little bit about natural language processing and narrative medicine and the opportunity that I see there. But lastly, I'll bring this into the context of talking about social determinants of health, which is an area where I think there's great potential, or at least a lot of researchers see great potential for making medical discoveries based on data that have not been traditionally used for research. But this is also an area where there's a huge amount of risk and, in fact, current problems relating to producing and reproducing racial health disparities and other kinds of health disparities. So those are the main parts of my talk that I want to address with you today. So let me start with narrative as an unstructured data problem. I'll just go through this quickly in case you are familiar with this. So, you know, up until I would say around 2010-ish, much of the discussion about AI in medicine was, there was research, but in terms of actual application, there was a lot more hype than there was actual application. But around this time, 2010, 2011, when IBM started to develop its Watson AI system specifically for use in healthcare, this was when computational research in medicine started to yield some tangible results. And this immediately led to research that looked at validating AI as compared to human performance of the same medical intervention. And the results of some studies that favored the algorithms in fields like dermatology, pathology, and radiology provoked a lot of anxiety about job displacement in the clinical specialties that so-called cognitive machines seemed poised to replace. So there were headlines from lots of medical organizations about these kinds of concerns. Will AI replace doctors? And early efforts involving the IBM AI were not very convincing, though, despite a lot of hype and a lot of worry. Famously, MD Anderson Cancer Center, which is based here in Houston, Texas, was an early adopter of IBM's Watson AI, and physicians tried out a prototype in the leukemia department at MD Anderson, but they ended up canceling the project back in around 2016 after spending $62 million on this effort. And this provokes the question, why spend so much money on AI investments before they even have proven benefits? And one important reason, of course, is the complexity of some widely prevalent health conditions such as cancer. You know, when we think about questions like, why do some people get cancer and others don't? Why do some respond to treatment and others don't? This is where you can see the promise of AI to mine vast data sets, right? If we could mine all of the medical data in the world and find a cure for difficult to treat cancers, and maybe even prevention, wouldn't you want to do that? So there, you can see the real use case here. However, the ultimate failure, the lack of delivery on these promises of this very expensive investment led ultimately not only to MD Anderson canceling their contract with IBM, but in January of this year, 2022, IBM sold off much of the Watson Health database to a company called Francisco Partners, which is a private equity firm in the United States, which paid $1 billion to buy those data sets. And some of the people who were involved in creating them, and many privacy advocates, are very concerned about the kinds of information that are contained in these data sets and what will happen to them. And the privacy concerns, something I'm not going to really focus on that much today, but I'm happy to talk about that in the Q&A more. So, but the reason I wanted to talk about this is much of the discussion about why Watson failed had to do with a mismatch between the seeming preponderance of big quantitative data sets in medicine and the reality that healthcare encounters occur not only between machines, but primarily between human beings who produce a lot of unstructured data in our health communications. So while data from lab results and vital sign measurements can be easy enough to feed into algorithms, the potential promise of medical AI has primarily been demonstrated in carefully controlled experiments. And in fact, as you can see on this quote here, the bulk of medical data in health, in electronic health records, for example, is narrative text, up to 80%. And that is described here as a stew of jargon, shorthand, and subjective statements, things that are not easy to quantify and to therefore construct as data sets that can be useful for training algorithms. So this is a problem that became very evident in the early efforts to use Watson Health. And so I want to look at what this means for thinking about unstructured data and narrative. And so this brings me into the part of the talk about narrative medicine and natural language processing. So scholarship in narrative medicine, if you're familiar with this, has laid the ground for research on narrative in unstructured text in patient records, in electronic health records, to be mined by artificial intelligence and machine learning. I think there's a clear need for teaching and research on the practical and ethical issues of conducting large-scale big data analysis of unstructured text in medicine, but this is a field that AI for health is really poised to expand through collaboration between computer science and humanities disciplines. The field of narrative medicine has been influential in clinical medicine for quite a number of years now. And I wanted to just kind of give you an overview in case you're not familiar with this, to sort of contextualize how I think this might be an area of opportunity. So some of the core ideas in narrative medicine are that patient stories are a vital component of the medical record. So not just quantitative data, but qualitative data is extremely important. That effort should be made to include patient narratives rather than allowing them to be replaced by generic drop-down menu selections, which is primarily how they are captured in electronic health records at this point. There's very little space for unstructured data. Major health organizations around the world have emphasized the need to incorporate patients' perspectives in healthcare and in research. And I think, to just kind of forecast ahead a little bit, one of the major reasons that social determinants of health data right now hold so much appeal for researchers is that they provide the fine-grained and nuanced descriptions that give meaning and context to individual lives, so that there's more of a holistic sense of who a person is, what their life has been like that has led them to this point, that may include potential insights on why they've gotten sick or what kinds of interventions might help them get well. Scholars in medical and health humanities, including medical doctors trained in this field, have used these concepts since at least the 1970s, recognizing the value of personal narratives as sources of perspective on patients' lives, and they've published accounts on the value of listening to, reading, and writing illness narratives as well. This has led somewhat, while the availability of unstructured data has led to some efforts to use natural language processing for healthcare to represent patient perspectives through computational health mining in a way that could potentially better integrate qualitative and quantitative data in patient records. So there's a recognition of the need for that in the kind of biomedical informatics literature. And one of the reasons for this is that there is a lot more nuance potentially, as I mentioned, that could be captured in a patient's narrative if that can be accessed through qualitative data. So NLP methods, I think, may need collaboration with humanities scholars in order to kind of, try to figure out what are the important intersubjective, social, and cultural contexts that need to be captured and that shouldn't be bracketed out when you're looking at sort of small chunks of data. as data sets are kind of curated for analysis and for training. So there has been some interesting research, for example, efforts to, again, analyze cancer narratives, the narratives of cancer patients, so that future patients could learn from the processes that others have gone through. So a group of researchers, for example, tried to use natural language processing to come up with something that they called an ethno-array. So they were inspired by the idea of a genetic array, and they wanted to try to figure out a way to kind of mine patient narratives so that they could highlight demographic characteristics and clinical conditions alongside decisions and the logic of decision making, as well as outcomes. This is kind of a it's a theoretical project in process, but it shows you the sorts of use cases that are at play right now. Some other researchers have looked at integrating analysis of clinical records, including the limited unstructured free text in clinical records, with user-generated content from outside of clinical settings, so social media, Twitter, Facebook, Reddit, Instagram, as well as online health communities. This is where you know, there's potential here for new discovery and also for major privacy infringements. So we'll probably come back. Another interesting approach that I've looked at was done by a group of researchers who tried to use Yelp to understand what mattered to patients about the care that they got at hospitals. And what they were motivated by the fact that in the US, there's this standard survey that is sent to patients, this HCAHPS, that's what that abbreviation is. It stands for, it's the name of a patient satisfaction survey. It's sent to patients after they've been discharged from hospitals. It's standardized, it's used all over the United States. And mostly it asks about things that patients don't care about, but that hospitals care about. And so these researchers looked at patient reviews of hospitals, which, you know, have many potential problems, but they looked at them to just see what they talked about. And what they found was that basically there's very little overlap between this official patient satisfaction survey and what patients actually talked about, which they found suggested that this provided a window into what mattered most to those reviewers. So it may be a source for thinking about what should actually be included in these surveys, for example. It gave a window into perspectives that was not otherwise available. So just to kind of sum up this section, there have been sizable text data sets that have been mined from social media and used to track all kinds of things, including mental health trends. That's been a recent effort including by companies like Facebook. And again, there's a lot to discuss there. There have also been a lot of efforts to analyze medical signal data that are collected on wearable sensors, for example, that may include some qualitative data in a more limited sense, like when people input maybe how they're feeling today or that kind of thing on a smartwatch on a regular basis. And then there have also been some efforts to use natural language processing to do things like assess drug interactions, for example. But one of the things that this really points to is the extent to which, although there's a sense that there's a lot of possibility in this field, actually when you do see genuine progress, it's often on something very narrowly focused, such as drug interaction. You know, the idea of being able to kind of mine somebody's whole social media feed and mesh that with their clinical record in order to learn things about their health and illness status is very far off from actually yielding really tangible results. But the thing is, people are trying, and that's what I want to get to in the last section here. So I'm going to kind of move into that. One of the main things I want to just emphasize as I move forward, though, is that making usable data sets in these text-heavy realms is a major obstacle because it's extremely labor-intensive. And so this has led to efforts to use deep learning, unsupervised deep learning, and that lack of supervision is where a lot of concerns come in. And further, concerns come in because of the fact that although there are many difficulties with using these kinds of qualitative data for predictive purposes or for informing treatment decisions in healthcare. Many hospitals, certainly across the United States, are partnering with cloud vendors like Amazon, Google, and Microsoft who are offering tools to search repositories of patient records and implement tools, AI tools that promise to improve care and save money. So I want to now spend the last little bit of my time here talking about how this plays out in the realm of social determinants of health and where I see some concerns with this, as well as some potential opportunities. So in case you're not familiar, this term social determinants of health, the World Health Organization defines it as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. So these are really, the factors beyond kind of, say, narrowly defined biomedical characteristics, beyond your genome. What are the factors, your access to education, race, religion, ethnicity, gender, sexual identity, all of these things, how they play into daily life. And this is very much a concern of the medical humanities. It's a concern of public health too, as distinct from medicine. And the main point I want to make right now is that social determinants of health really speak to things that occur outside of clinical settings, right? So when you go to a clinical setting, you might get your blood pressure measured, you might get your weight or your temperature. These are things that are, clinical measurements that can be made, but those are not social determinants of health. The data that you can get from someone's social media feed, for example, might potentially speak to how they are experiencing, say, racism in their daily life and how that may be impacting health outcomes and that sort of thing. So this all occurs in a realm that I call meta-clinical, and it's user-generated health data. It's, like I said, your social media feed and that sort of thing. But these are messy, voluminous, and heterogeneous data, unlike many kinds of clinical data, which are captured under carefully controlled settings. And so because of this messiness, this really creates an opportunity or sort of a demand for tools like AI. And I'll just, without going into a lot of detail, I will just say that the big differentiation between clinical and metaclinical is that in the United States, most consumer-facing apps and devices are not regulated by the US Food and Drug Administration or covered by health privacy law, whereas clinical-facing apps and devices are. So this has led to a situation where outside of clinical settings, technology companies can exploit practices of health datafication, basically, in order to create AI systems that are trained on data scraped from social media and other forms of data. And I will mention that in the EU, in Germany, for example, GDPR does offer some protection. I'm sure you all know a lot about this, but many violations continue. These are just a few examples. So just to kind of pull this together with one final example so you can see kind of where I see the risk with social determinants of health. Social determinants of health has become a major kind of buzzword in healthcare settings in the United States. And it is precisely the term that allows that healthcare, this is driven by health policy reform, I should say. So healthcare organizations are trying to assess the health of populations, and to do so, they're looking at social determinants of health. And AI companies are basically saying, we can help you do that. We know that this is data that's beyond your scope of practice. And so they offer things like, this is just from one company, what they call prescriptive analytics for preventable harm. These are all risk profiling tools that basically use a lot of data from outside of clinical settings. Here's another example. In order to predict what different patients will cost, more so than what kinds of care they need. And so they look at things like criminal records, housing records. They also look at things like voting records, retail loyalty programs, online purchasing histories, all of these kinds of things. So you can see, so this is how social determinants of health fit in. These companies, they produce risk profiles with scores that look at things like, you know, are you a smoker? How are your personal finances, your education? Have you had encounters with law enforcement? Do you vote regularly? And use that to produce a risk score that then is fed into a clinical algorithm that guides how care is provided. Okay, and this, of course, leads to the potential for algorithmic bias. So I think I will just stop with the discussion of social determinants of health here, and I'll just say that the last point that I want to close on, because this seems, you could look at this and think, okay, well, you know, social media should be barred from any kind of clinical algorithm. But the thing that makes this more complicated is that actually patient groups have found a great deal of value in sharing data with one another through online communities. And because of this, they have things like patient Facebook groups where all kinds of personally identifiable health information might be posted, like what you see in the list here, which can easily then be scraped by third parties and fed back into these algorithms. But for the purposes of the people involved in these groups, learning from the information that they share with one another already has a proven value and may have further value, despite the fact that they don't like at all the experience of being targeted and mined for purposes that may not serve them. So what I just really want to emphasize is that the use case for bringing this kind of data into training data sets is there from the patient perspective and from a corporate perspective. And the benefits are not clear in either direction, but there's enough interest that this is an active site of research. And this is what motivates me to look at how we can think about, through a more ethical lens, how the humanities might inform narrative data mining in such a way that might be more beneficial to patients rather than to corporations. So I'm really eager to hear your thoughts on this, and I will stop sharing my screen there, and thank you very much for your attention.